Morning, everyone. So I'll be discussing my approach to these areas. I have no relevant disclosures. So as we take a look at the eye area, we see a multitude of changes that take place as we age. So we see lid and brow ptosis. We see advancing skin laxity. We see volume loss resulting in a tear trough deformity. We see periorbital discoloration, so dark circles and prominent vasculature. And we see textural changes, such as increasing dynamic and statid rhytids and crepiness. So really the best approach to this area is to use a combination of different tools. In general, I always recommend first starting with treatment with neuromodulator. I never do this on the same day as a laser or energy-based device treatment, and ideally I do this about 2 weeks prior to any of those other treatments. I then am going to discuss lasers for vasculature or pigmentation, followed by resurfacing and tightening techniques, and then finally filler to restore any volume loss if appropriate. So we know neuromodulators, of course, are injectable medications. They temporarily inhibit certain facial expressions that create lines. There are multiple muscular targets for the purposes of this talk in this area. So what I really focus on for the periorbital area is treatment of the glabellar complex. This gives patients about 1 to 2 millimeters of brow lift if performed appropriately, as well as an eye-opening effect, as well as treatment of the orbicularis oculi to soften any crow's feet. In terms of periorbital discoloration, so there's a few different lasers that you can choose for this area. So if a patient has prominent periorbital blue veins, you can do a 1064 nanometer long pulsed YAG laser. If a patient has more periorbital just vascular congestion, I like to use this same laser in a laser genesis mode, which is a shorter pulse duration. In terms of dark circles, so these can be, of course, difficult to treat. I typically do a combination of topical therapy, and you can do either picotoning or a 1927 nanometer thulium laser. And then it's imperative to say that any of these lasers in this eye area require placement of a metal intraocular shield. And this is just an example of a patient with a blue vascular lesion in the infraorbital area treated with one session of the long pulse 1064. And then I typically move on to treatment with our energy-based devices that resurface and tighten the skin. These can be done on the same day as our color treating lasers. So there's a few different technologies that I use frequently in my clinic, starting with the least invasive, least aggressive, radiofrequency microneedling. So this is a dual technology device that simultaneously microneedles the surface while delivering bipolar radiofrequency heat deeper down to stimulate collagen production. We have a couple of these devices in my clinic, so just showing a video of me performing one of these treatments. These treatments are typically best for patients who have early changes. Perhaps they're trying to be preventative. We typically do this as a series of 3 to 4 treatment sessions performed monthly. It takes about 3 to 6 months to see the full amount of tissue tightening after they complete their series. But this is a good choice for patients who don't want or can't tolerate a lot of downtime, as they typically have 24 hours of erythema after. Another less invasive technology is monopolar radiofrequency. So this device really doesn't help a lot with, in my opinion, textural changes or fine lines, but it does help with lid laxity, and I especially think it's helpful for upper lid laxity. And this is typically a single treatment session that would be performed every 1 to 3 years. Same thing, any of these non-surgical tightening devices, it's really going to take about 3 to 6 months to visualize your full results. Then moving into our laser resurfacing options. So we, of course, have non-ablatives as well as ablatives. So with our non-ablatives, we're really just delivering microcolumns of heat into the dermis to stimulate collagen production. You'll probably recognize this patient here. But this is just how you deliver these non-ablative treatments. We have a few of these devices. They're typically done in this rolling mechanism. When I treat around the periorbital area, I use these iPads, but of course, if I'm treating eyelid skin, I'm placing an eyelid, an intraocular eye shield. And then ablative resurfacing, I really think this is king for treating laxity in the periorbital area non-surgically. So our options are either CO2 or erbium. I do have both of them in my clinic. I use both frequently, but I think for the periorbital area, I vastly prefer fractionated CO2. I think it goes deeper in the dermis, has more coagulation, and therefore get more tissue tightening afterward. So this is my technique. So I typically do the entire face first, and then I save the periorbital area last. And then you can see this patient's, I have her open her eyes, you can see placement of that metal shield, so I'm able to treat really right up to the upper and lower lash line. And then in terms of injectables for this area, so this is really reserved just for the tear trough area, and it's really important that you choose careful patient selection here. If a patient has any kind of herniated infraorbital fat pad, any kind of festooning, they're really more appropriate for an oculoplastic consultation for lower blepharoplasty and fat pad removal or transposition. But in patients where they truly just have hollowing, I think injectables can play a role here. So the choices are HA fillers, collagen boosters, skin boosters, or things like PRP. And typically my technique for injecting this area, so I try to do as much as I can with the cannula. I use an AccuVein to choose an insertion point away from any vasculature, and then I'm injecting in a deep dermal subcutaneous plane here. So just kind of filling out this area. And then I use backfilled BD syringes to access any areas that I'm not able to with my cannula. So I use this typically around the medial canthal area as well as along the lateral orbital rim. And this gives a nice result. Usually I do recommend tissue tightening prior to this treatment, especially if a patient's going to do both treatments. And then just a couple of examples. So this is a patient where we performed neuromodulator 2 weeks prior to fractional CO2 resurfacing, so nice result. We did not follow up with any injectables. This is a patient similarly did neuromodulator to open up the eye area, lift the brows, soften crow's feet, and then performed fractional CO2 resurfacing followed by injectable skin booster in the infraorbital area. And then as we approach the perioral area, so similarly, we see a lot of changes with age. One of the most common things patients come in to me for are prominent perioral rhytids, or those vertical lip lines. We also see a lot of volume loss in this area. So we start to lose the support structure around the mouth. We see an elongated upper cutaneous lip. We see marionette lines, jowling, and then textural changes as well. So I practice in Arizona. I see a lot of solar elastosis. So kind of same algorithm I follow. So I always start first with relaxing with neuromodulators. I think this is so important, even in patients when I'm doing fully ablative laser resurfacing in this area. Studies have consistently shown we get better results if we're able to relax those muscles both before and after treatment. Then I focus on resurfacing and tightening options, and then we'll follow up with filler. So in terms of targets for neuromodulator, so your orbicularis oris, the depressor anguli oris muscles, and mentalis. I typically do 2 injection points at the upper vermilion border and 1 to 2 at the lower, using 1 to 2 units of botulinum toxin per site. This is a great treatment. It's both preventative as well as corrective, but it's very important you counsel your patients that it will weaken their pursing motion, it will feel funny when they drink through a straw, and you have to make sure your patients are prepared for that. And then these are just injection points for the depressor anguli oris, and then mentalis, which can be done as either 1 or 2 injection points. And then in terms of tightening, so kind of similar, we have a few different options depending on what the patient's needs are and what downtime they can tolerate. So radiofrequency microneedling, again, I do this a lot as a first option for patients, just starting to notice those lip lines, perhaps wanting to be preventative and comfortable with multiple treatments. And then, of course, I do non-ablative fractional laser resurfacing, and then I do a lot of ablative laser resurfacing. You can, of course, do fractionated CO2, so that's what I'm demonstrating in this video. I have more recently gravitated toward performing fully ablative erbium in a lot of my patients, especially patients who have just advanced lip lines. You really can't substitute the results that you're able to get from those fully ablative procedures. And I'll often even do that and then fractional CO2 the rest of the face. And then kind of the new kid on the block, so tissue microcoring. So this is utilizing a completely different technology. We're removing true microcores of skin that are allowed to then close and provide tissue tightening that we previously haven't seen with other non-surgical devices. So here I am demonstrating this device. This is a good option. I would say patients that really have more advanced lip lines, I'm probably leaning more toward an ablative option. But for younger patients who are experiencing both laxity and some early changes, or really for patients who are looking for a non-surgical lip lift, I think this can be a really helpful tool. And then in terms of injectables in this area, so I do this a lot. I, of course, do this as monotherapy for patients who don't want any laser or device treatment, but I think this is a helpful follow-up tool for patients, especially if they're not going the fully ablative route. They probably will still see some lip lines and changes after their treatments, and I think this is a nice follow-up. Again, I use HA fillers, skin boosters, and collagen boosters in this area. When I'm part of injecting the lower face with filler is volume restoration, so providing more of that perioral support structure. I primarily do that with a cannula, but when I'm truly injecting that perioral area, I am taking my syringe, backfilling it into these little BD syringes so I have more precision. I typically start by outlining the vermilion in patients. So obviously this looks nice in a young patient who just wants more definition, but in older patients, we really start to see that curling inward of the lip. And if you're able to just redefine that border, it does smooth the lines quite a bit. It also builds a little bit of vertical height, so you decrease that lengthened upper cutaneous lip. And then this is my technique for treating these perioral rhytids. So come at it from a perpendicular approach, just using small aliquots into the lines themselves. Luckily, we now have really elegant HA products that are very elastic and appropriate for placement in the superficial plane. So there's a patient immediately after that filler treatment. You can see even without neuromodulator, it significantly weakens that pursing motion. And then just a couple of examples of combination therapy. So this is a patient I've done multiple treatments on over the years. Neuromodulator filler, we had done fractional CO2 probably 3 years ago, and more recently came to me and was like, I just want a little more improvement. So here I did 5 passes of fully ablative erbium on her, and this is her 18 days after treatment. So they do have some residual post-treatment erythema even after the 2-week healing period, but I feel the results are quite impressive, and there's just a side view. So these photos are taken about 5 years apart. And then this is another patient where I performed that fully ablative erbium treatment. She actually only wanted non-ablative fractional resurfacing on the rest of her face, but nice result from that. So final recommendations, neuromodulator first, lasers and devices every 1 to 5 years, depending what technology you choose, and then filler, every 9 to 24 months, depending on the patient. And then obviously what we do procedurally, maybe is 80% of the work, but I do think what patients do at home matters as well. So I always make sure to set patients up with a really good post-care and topical regimen. So you can use things like PRP or exosomes post-procedure. I use a post-procedure nectar on my patients, specifically with ablative. Using skincare products that have peptides, antioxidants, retinoids. Of course, good sunscreen. There are some products that are topical HA that just kind of temporarily fill lines. So they're temporary, but they make patients feel better. And then for the eye area, I do recommend a caffeine-containing eye cream. And that's it. Thank you. And that's my girl.